Hello everyone. Good afternoon. My name is Bonnie Jacob. And I think, like all of you, I'm very excited about our presentation this afternoon, who I will introduce in a moment. But first, I want to tell a brief story, since this is our last Deaf Hub Exploring Perspectives presentation of this academic year. So, science, when we talk about science, science is amazing, right? But science is not always perfect. Have you ever heard of the term a refrigerator mother? Has anyone heard that before? So many years ago, it's a term that came from scientists who blamed mothers for conditions such as autism. Scientists thought that if a child had autism, it was because the mother was bad. They blamed refrigerator mothers for their children having autism. And then, of course, many people, including many parents, fought that and fought for more research. And as scientists did more research, they realized that that was incorrect, that it's not the mother's fault. There's no blame on the mother. It's not that they did anything wrong if their child has autism. The point I want to make is that we do need science, and science needs us. Like the mothers who had to push against the trend and fight for more research, it's the hard times that matter. They had to fix that mistake. They had to fight through those hard times, and we have to continue that. And this is precisely when we all need to stand up for science. And we also need to celebrate. We need to celebrate ourselves, celebrate each other, and we need to celebrate. One thing specifically I want to mention is that here in Rochester we have an incredible pipeline to support deaf scientists. Many people have been involved in setting up that pipeline over the years. It was painstakingly created by the deaf science community here in Rochester to support students, graduate students, PhD students, postdocs, and faculty. And I would miss people if I tried to name all of them, but many wonderful people have gone through those programs. So it's very important to recognize that today, and that's why we're here today. Without further ado, I'd like to introduce our presenter, who is also a researcher worth celebrating, Michelle Koplitz. Michelle is a fourth-year Translational Biomedical Sciences PhD trainee at the University of Rochester School of Medicine and Dentistry. Her research interest is focused on how the deficit-based model of deafness that's used by EHDI systems impacts the developmental trajectory and associated long-term health outcomes in deaf and hard of hearing populations. Previously, Michelle worked for 10 years in federal service as a project officer for the Health Resources and Services Administration's, HRSA or HRSA's, Early Hearing Detection and Intervention, EHDI program, which is in the Maternal and Child Health Bureau. In her free time, Michelle likes to practice yoga, rock climb, run, and spend time with friends. Thank you very much, Michelle. I have a lot to share with you this afternoon, I hope to share some of my work experience and why I'm doing the research that I'm doing now. And I also want to briefly mention the deaf scientist pipeline that Bonnie mentioned. There is some news about that I'll briefly talk about at the end of today's presentation too. So if you have any questions about that, please hold them until the end. I will talk about that a little bit more and share some updates. Okay, so this is what I plan to cover today, what the EHDI system is all about, the purpose and why it's important. And it's important for the deaf community to be aware of that system. And if you're interested in working within that system, that's great too. I also want to show how science is used with policy to promote systems like this within the field and for people in the field who are doing work within our community. These are the topics that I'll cover today. All right, we'll start with some background. First, I'll share a little bit about myself. I am from Wisconsin, Eau Claire. I grew up there with my family. My parents are both hearing, but my mom is a CODA, so I'm very fortunate that she already knew ASL when I was born. And then I also have a deaf brother and a deaf sister, which is very cool. So we used both ASL and English at home growing up. I came to Rochester to be a student at RIT. I graduated in 2008 with my biotechnology degree from here. And I was so glad to connect with the deaf community here. I loved being here. After that, I did some lab research experience and I really didn't enjoy my internship. So I realized that I was too much of a people person to be working alone at a lab bench all the time. Some people really enjoy that, but it was not for me. I really like interacting with other people, and I really like community-based work. So that's how I landed on public health. And again, this was a while ago. This was in 2007, 2008. At that time, no one had ever mentioned public health to me as a career option when I was a student here. It was still very new at that time. Not many schools had a public health program at all, but I looked into it and I found some graduate schools that did. I sent out some applications and I really wanted to get into graduate school because I really didn't want to go work in a lab yet. Luckily, I was accepted to one school. I ended up going to Johns Hopkins, which was my wild card school. I applied not really expecting to be accepted, but I was. And so I ended up going there. I moved to Baltimore, Maryland, and I went to grad school there for 2 years. And I loved it. I fell in love with public health. It was so cool. It was also very global. They had a lot of international students and international presenters who talked about the communities in their countries, different populations that they serve. And also the different types of work that they do too, from maternal and child health to epidemiology to virology and vaccine development and distribution. It was really incredible how many different areas and how broad of a field it is, and the skills and experience that I had could apply in many different ways, which I thought was very cool. So I knew that I wanted the deaf community and I wanted health. I really enjoyed the healthcare field and I enjoyed being in the deaf community from my experience here at RIT. But I wasn't really sure how that would look for my future career. I honestly didn't know how I could do that at that time. There were no job opportunities for deaf people in public health or as public health practitioners. So I knew I wanted to do public health. I decided to go into that. And then hopefully if something came up later, I would figure it out. I was pretty optimistic. So I got my certificate in health finance and management. And then I got my master's in health education and health communications. Again, thinking about language in the deaf community and wanting to learn more about how to communicate with the deaf community about health education and health topics and programmatic activities. So I moved to Washington, D.C. after I graduated from Johns Hopkins, and I still wasn't sure what I wanted to do or what my job would look like, so I sent out a few different applications. At that time, the current presidential administration was Obama, which was very fortunate because they were very supportive of health and disabilities, and they were very aggressive about hiring people with disabilities to work in the federal government. So I shared my resume, and my resume ended up at an agency that contacted me for an interview. That was in 2008, so some of you may be too young to remember this well, but the economy crashed. There was a very severe recession around that time too, And so I just needed a job. I would take any job. I just wanted to find a job, stay in DC, get some work experience, and figure it out later. The federal government is known for providing good accessibility and sign language services, so I thought that would be a safe bet. I was offered my job at HRSA, HRSA, and so I accepted and I started working there. I thought at the time I would stay there for maybe a year or two, and then I ended up staying there for over 10 years. And I realized that I found something I really, really enjoyed while I was working there, and I'll talk more about that later. And then now, obviously, I'm back in Rochester as a PhD student. I left my job in 2021 and decided to pursue a PhD to be able to do more research in the field related to EHDI. This is a little bit corny, but I do want to be positive and optimistic, especially about changes in the system that are happening with EHDI right now. Do you know who Claudia Gordon is? Anyone recognize that name? Claudia Gordon? She was the first Black deaf woman who became a lawyer. She lives in DC, and this is her quote. This is actually on a staircase in DC, and it was painted for disability awareness. I took a picture of it because it was so cool and so inspiring. Right, so again, I used to work for the federal government. I do not work for the federal government anymore. I just want to make sure that's clear. So I don't know if you all know this meme or not, but a lot of people ask, what is EHDI? What does that mean? Anytime I say it, people ask, is EHDI a person? No, it's EHDI. Does anyone know EHDI already? No one knows what EHDI is? Do you know? Okay, yeah, of course you know. Okay, but are you hearing or deaf? You're hearing, okay. Who is deaf who knows what EHDI is? Anyone? Any deaf people? Where are you? Okay, do you know what EHDI is? Okay, 1 or 2 yeses. Finally, wonderful. Okay. EHDI is early hearing detection and intervention. It is very important. Now, when babies are born in a hospital, all of them are required to have a hearing screening. You're an audiologist, you know this already. Okay. So all hospitals will give babies a newborn screening for hearing before they leave the hospital. Most infants, almost all infants, are screened at birth, which is fantastic. And the goal is to screen early, because earlier detection means earlier services for deaf babies. So if they find that they are deaf, they can refer them to an audiologist. And if the audiologist confirms that they are deaf or hard of hearing, then they can refer them and make a connection with state services for language intervention or to get more clinical health services. This is current data from 2022 from the CDC. The goal is 40% by 6 months are enrolled in early intervention. That's a change in the timeline recently to try for earlier intervention. In the United States and in territories such as Guam, Puerto Rico, Marshall Islands, all of them have different programs.
Hearing people think that this is a great system to make sure that babies are identified as being deaf immediately, so we know exactly what they need. So hearing people think, hurrah, we have found all the deaf babies. Do you think that's necessarily true? Well, it's not. Of course it's not. It's not as simple as it seems. So why am I talking with you about EHDI? So if we could go back and talk about language and human cognitive development. Oh, I didn't realize the bottom of this slide was cut off. But this shows that at birth, babies start learning about the world. So if it was a hearing baby, typically they would start hearing sounds immediately. They hear their family members talking, they hear their family members laughing, singing, they hear the sounds of the world around them. And then over time, those sounds become words, and they begin piecing the words together to make sentences. And then from there, that starts their cognitive development of language. Expressive and receptive language. That's their way of interacting with the world. That's a pretty typical process. For hearing babies, that process just happens. They are passive listeners from birth. They don't have to work at it at all. But for deaf babies, what happens? That's a completely different story, right? Why is the timing that's showed up here on the graph important? What do you think this represents? Can you guess that age? It's about 5 or 6 years old, and that's the time, a critical period of language development and brain development. Exposure during this period of time is critical. If after, it causes delay, cognitive processing issues, and other issues or disorders could develop later in life as well. So the earlier the language exposure, the better.
And that means the earlier the hearing screening, the better.
So language impacts basically every part of your life. It's actually a beautiful thing to have a language. But why are we talking about this? Why are we concerned about deaf children? Because we do see that some deaf kids do just fine, while others have a really hard time in life. People thought that by identifying deafness at birth, that would solve a lot of the problems, but it's actually more complicated than it looks. These graphs here are from a famous cochlear implant study that looks at the timing of implantation of young children. And the graphs are also showing us that it's from a deaf researcher. The graphs on the bottom is language expression, and what you see at the top is comprehension success. It tests this after the child has been implanted. It's not all uniform. The black line that you see at the top of most of these graphs is a typical hearing child. So these children can get cochlear implants as early as 18 months, and the assumption is that they would have better results with earlier implantation. One line equals one child. So you can see that there are a lot of markings on each graph, and the earlier the age of implantation, the better, because the lines are closer together, but it's still not great results. And there is a lot of variation in the research to show that the outcomes of young children receiving cochlear implants is not consistent. So language can impact academics. Often parents are told that their children will develop other problems. So in addition to worrying about one thing, there are other things the parents start to be concerned about: developmental delays, emotional and behavioral issues, ADHD. So We wanted to take a better look at this, just so we can understand some of these outcomes. There is something called adverse childhood experiences. So what that really means is that what a person experiences as a child really does have long-term impacts on them. This is a public health concept, and outcomes have been researched that if someone were to experience abuse as a child or saw a parent experiencing abuse, had a parent who was incarcerated, did not have parents in the home, grew up in extreme poverty, or saw regular drug use happening in their home, those children who experienced that had serious health effects later. So we're trying to understand that if language barriers has one of these serious health effects, is lack of communication similar to neglect? So these are, well, the not having communication with parents is directly a deaf experience, but there are some other direct outcomes. There is a deaf researcher named Poorna Kashaulnagar. She has a very long last name, but she does a lot of research regarding health, and she is at Gallaudet University right now. So what you see here is that if there are language barriers, that can impact all of the other aspects of a person's life. You're all aware of language deprivation, right? So why is this important to research? Now, it's important for researchers to identify what's happening, to help people understand the situations. If deaf people don't have access to language, and that causes problems later in life, there needs to be a label for that. And that's where language deprivation comes in. Language deprivation is a systemic issue. It's not necessarily a direct issue. Sometimes children who don't have access to language at home continue to miss information later in life because it has impacted their cognitive growth and development. It's not just a once in a while type of impact. It impacts the children every day of their lives. They miss a lot of information. There's serious impacts on language acquisition as well as other parts of their lives. Now, going back to EHDI, why is EHDI important? Because this is where parents are first going to see their baby as deaf and learn what the resources are, how they can find out about their baby as a deaf person. And yes, the screenings are done in the hospital by a doctor. There are audiological clinicians that are working with the parents. There can be all sorts of resources, but there may not be complete information shared about the other options available. A lot of clinical providers only have access to medical research, medical journals, and the information that's available in that medical field. There is deaf research available, but it is very often overlooked, or people are unaware that it's available. I'll go back to that point in just a little bit. But one of my points is that deaf children are born already with a specific challenge. big picture. So I'm going to try and clarify all of this for you. If you don't understand any of the details, please raise your hand and I will try to clarify for you. But EHDI is a federal law. It was passed in 1999. It was a regulation that required babies to be screened for hearing loss at birth in all 50 states. Now there are a lot of state agencies that are being established for hearing tests in hospitals. It's been a very positive introduction. So the most recent version update of this law has been reauthorized as recent as 2022. The law says it must go through, the law goes through the Department of Health and Human Services. And that lays out several requirements for the states. HHS has 3 agencies that are responsible for supporting the EHDI system. I'm sure you're familiar with the NIH. They focus on hearing research, some language research, but mostly hearing. HRSA, HRSA, that's where I used to work, and I will give you a little more information on that in just a minute. And HRSA is a state program. Also included in this as an agency is the CDC. They look at the epidemiology, they track and collect data from the states. They see how many babies born were screened and identified as deaf. And then they want to know the numbers and the data of how many were screened, how many are deaf, and how many have been referred out. So that's the HHS system.
Each of those agencies has their own sub-programs that are listed here. I'll focus on HRSA. So HRSA is based in Rockville, Maryland. And when I was making this presentation, I looked, and the new administration has changed a lot of these different agencies, including HRSA. So it looks very different from the presentations that I've given before. The agency mission has changed. I just want to share that information with you. This is the agency mission from 2019 in red text: to improve health and achieve health equity. And then the new text is to improve health outcomes. And they also added high-value programs. So that's a change that's happened with the new administration recently. So many people have not heard about HRSA because it is fairly small. There's only about 2,000 maybe staff who work there, where other agencies like NIH have 40,000 staff. So there's a big difference in sizes. HRSA is very small compared to some of the other federal agencies. But HRSA has a budget of about maybe $5 billion. They do have a lot of funding. They have a large budget. What they do is provide grant programming to states and health centers. So most of the money that goes through HRSA actually goes out to states across the United States. But they manage the money and they manage the grant programs that fund those state programs. Where NIH, the staff at NIH do research themselves, and they also disperse grants. So that's why NIH has so much more staff than HRSA. CDC is similar. CDC also monitors. They have a large epidemiology staff, and they have a larger budget because they also give grants, where HRSA, almost all of the money is given out through grants.
So when I started at HRSA, I originally started in the Bureau of the Health Workforce, and specifically in the Division of Nursing, and I worked there for 3 years. I had no background. I didn't know anything about nursing, but I worked on some programs and I learned more about it.
And then later on, someone came to me and didn't know. I was at my job one day. It was actually in the elevator. And someone came up to me and said, "You're deaf, right?" And I thought, because I wasn't using sign language, I was just standing in the elevator. But I said, "Yes, I am." And they said, "There's a hearing screening program in another bureau. You should talk with them." And I thought, that's interesting. Around the same time, I also spoke with the NAD, National Association of the Deaf president, and they had mentioned that the EHDI program is also at HRSA, and I just didn't know. I hadn't known until that point that the EHDI program was run out of HRSA when I started in my job. So I found out from other people. I did reach out and contact them, and I said that I wanted an informational interview. I wanted to learn what I could about that program because my goal was eventually to work with that program because it affects deaf people in the deaf community. That's where I want to work. And that's where the Maternal and Child Health Bureau is. So the Maternal and Child Health Bureau obviously runs many programs for mothers and children. They do some house programs, programs for people with disabilities, and it also includes the EHDI program. So when I say program, what exactly do I mean? Program means a grant-funded program that the agency sets up for states to apply to. And then the money comes from the federal government to the states so that they can implement that program and do the work. They have to do some work to set up the newborn hearing screening, and they have to follow the actions that are outlined in the legislature. And to do that, they have to have programs in place. So there are quite a few different programs at the agency that cover different purposes. There are 5 programs within the EHDI portfolio, and each of them have different purposes. One supports states, so every state and United States territory gets funding to do the newborn hearing screening, to do coordination, data collection, outreach, provide resources to hospitals, everything along those lines. Another grant is for a technical assistance agency to be able to provide support to those hospitals and states doing the work.
And now this recently changed, but these are the National Technical Assistance Centers. And now we have the Beacon Center at Gallaudet University, so it is now run by deaf people. Previously, it has always been run by hearing people for the last 20 years. And now it is finally established at Gallaudet University, which is a huge improvement.
Because it's led by deaf people. There's also technical assistance for family support. So when families find out that their child is deaf, they can contact this type of organization to provide additional support for them. And then there's also the American Academy of Pediatrics. That supports pediatricians and audiologists to know what they do when they're treating a deaf child in their practice.
And then the AUCD also provides scholarship funding for audiology students as well.
So all of these have a budget of about $18 million that goes out through these different programs. Does anyone know what this is? Anyone familiar with this screenshot on the right? This is called a NOFO, N-O-F-O, a Notice of Funding Opportunity. That is the grant program that specifically outlines what states or people who apply to it, what they're supposed to do with that funding if they receive it. So the government tells them, we want you to do this, this, and this. That's all outlined here in the NOFO. And then states apply for the funding. So that's it, NOFO. How a NOFO is made requires a lot of thought. We started developing the NOFO maybe 1 year or even sometimes 2 years before it's actually released to the public for people to be able to apply to it. It takes a couple years of planning that goes into it because there are so many different parts involved. There's a lot of different people, information, systems, policies. Research scientists are included in that too. It starts with the legislation, what the legislation actually says. We have to make sure that we're in alignment. And then the priorities of the agencies, that includes HHS, HRSA, needs assessments. Often states or organizations for parents or community members will say that they need these things. There are these gaps in services that they're seeing. And so we're looking for areas where communities need additional support. We're collecting that information and looking through that data to do the needs assessment. We also host stakeholder input. So there is something called the Federal Register Notice. And the Federal Register Notice is basically if the federal government is making changes to a program, they have an opportunity for community input. So anyone can give feedback through that system on a program or a grant application, any changes that the federal government would be making. So we collect all of that data from the public, we summarize it, we analyze it, and then at the end we look for what people are bringing up most often. Sometimes organizations will also contact us and say that they're interested in doing this specific thing in the future, they want funding for this program, they care about this issue. So for example, cochlear implant companies reached out to us. The Cochlear Implant Alliance, which is an organization that reached out to us. We've had contact with other family organizations that have contacted us. So many different community groups, pediatricians groups have also contacted us, audiologists, or basically anyone who is lobbying for certain things or who wants to see their opinion and their input involved in the programmatic planning. That's part of the puzzle. And then SMEs, subject matter experts, are also important. Those are the people, typically researchers, who are doing literature reviews, who have published articles in that area, who have worked in the field for many years, and who have a good understanding of the landscape and are able to advise the agency on what should happen. So the agency also listens to their perspective and considers their expertise as well. And then this is the NSCH, the National Survey of Children's Health. And then some of the agencies also conduct their own surveys. And typically the Census Bureau sends out those surveys. So we have that data set about children. There is one question in that data set about deaf children, so that we're able to find the prevalence of deaf children in that survey. And I'm actually using part of that survey for my dissertation, which is nice to see it come full circle for me. We also have project officers like myself, my former job, who are working with grantees who may be complaining about an issue that's coming up in their state or asking for additional support with something or whatever else it may be. There's a lot of information that the agency collects, analyzes, filters through, and then summarizes into the end program. On top of this, there's also the Bureau Strategic Plan as well. And they consider what the budget is, what the budget looks like for each of those different programs. Do they keep flat funding? Do they increase or decrease the funding? Sometimes there's a plan for incremental funding increases. States also submit annual performance reports on what they're doing, so they review state performances. And then there's also an idea repository. So that's planning ahead and thinking about other ideas that the agency could implement too. It's important that the agency continues evolving with time and keeps up with changes in the field. From there, there's program development. That's the NOFO development. Program implementation, data collection, data analysis. And then also from when I previously worked there, I can also explain the process of what we went through in 1 year, which is a lot. We had different officers at the agency who would come talk with us about each of the different steps in the process. The budget people would come talk to us, the policy people would come talk to us, the data people would come talk to us. There were a lot of people involved with this entire process, and that's part of the reason why it takes a year or two sometimes to get all the way through the process. So this is where the program development really happens. That's where my job was focused. And again, that comes from the EHDI legislation in the first place. Now, EHDI policy is reauthorized every 4 to 5 years. But each of those times that it's reauthorized, basically it ends, and sometimes that ending doesn't align, the reauthorization doesn't align with the grant year. So we also had to work with this program in 2017. This was a new grant year, and they had recently passed some new policies in the EHDI reauthorization. So the program had to look into this, into the legislation for guidance on what needed to be included in new programs. So what I did was have the old policy on one side, the new policy on the other side, and then I went through and highlighted every single change that was made. This is just for the EHDI legislation. Not all programs have legislation. That's a different type of process. But for this, and it also depends on, some programs have level funding, so that's a different story too. But this legislation determines how much funding we get every year. So you can see here in 2017, when it was reauthorized, they laid out each of the budget amounts for the following 5 years, 2018, 19, 20, 21, and 22. And so that is the amount of funding that the agency got in every one of those years. There is a slight increase year to year, so that's helpful. But every time they reauthorize the legislation, that budget could change. It's really hard to predict what it would look like year to year. Something that was new in 2017 is that they finally added language about language acquisition in oral and visual modalities. That was very cool. That was a great addition.
That's more information about the creation of the NOFO. Just in case you've forgotten what it looks like, here it is again. Another HHS agency, NIH, also creates NOFOs for their grants. The CDC does something similar, and I'm sure that other agencies follow the same grant structure. Now that the boring stuff is out of the way, why is the deaf experience important to all of this? And where can deaf people fit in and contribute their experiences? I've talked about different ways that people can contribute to the program planning process. You might remember that $18 million from regular old folks who are paying their tax dollars contribute to this work. So people in the community have the right to give their input. So in the legislation, people have lobbied for organizations like the NAD and other organizations. They have been fighting for changes to be made to this legislation. And so they're aggressively seeking the right to give input and make specific changes in the program. So individuals and deaf organizations have been doing this. Subject matter experts like hearing researchers and deaf researchers have been involved in being considered a subject matter expert, people who work with deaf children as well. So where do deaf people like us fit in? There's a lot of policy. There's a lot of change that needs to happen. How do we include everyone? Also, when I was working there, I had to be neutral. I thought that every deaf baby needs to learn ASL, but if I mentioned that, I would likely be fired. I had to be very neutral, and that was a really big challenge for me. It was hard for me to deal with that. I had all hearing people on my team, a hearing supervisor, hearing managers, and they didn't know anything about the deaf community or deaf culture or ASL. They didn't know who the community involved. They didn't know any of our community leaders. They didn't know language deprivation or deaf researchers. So I had to bring in some new information for them so they would understand language deprivation from the perspective of a deaf researcher. So I was able to bring a lot of new information to the table.
And I was able to use the actual legislation. So there's one word that I could point to that we had to include in the program because it's so important. Language acquisition in visual modalities is important, and it is said in the legislation, so therefore it must be in the NOFO as well. And my boss couldn't argue with me about that.
It was right there in the legislation. We looked at other policies and other guidelines that were available, and we tried to use what they had. And I was not allowed to incorporate my own opinion. So this policy here was the most helpful in making some change. Another thing that provided a lot of support to us was there was a part on consumers. This is legalese here, but
Those who are using or receiving a service are considered consumers, so the deaf person is considered a consumer.
so we used the term consumers, and I'm not fond of that word, but we had to talk about consumer groups and how they were involved in this whole system.
So then I could say in the program to make sure that deaf people in their states are involved with their EHDI newborn screening systems. That was an important part of the program. There are others involved like clinicians, parents, youth and school educators, but so far deaf people had not been involved in that system for many years. But now I was able to point this out, just these one or two important words, and that would encourage states to develop a relationship with their local state deaf communities. And I gave a presentation at the National Association of State Agencies of the Deaf. So many states have their own Office of the Deaf and Hard of Hearing.
Some states have a council, some have a department, and they manage deaf services in their state. So there are a lot of state agencies and organizations that work with deaf and hard of hearing folks. So we would go to these organizations, or people would present to these organizations on the importance of EHDI and ask them to share this information with other deaf folks in the state, other audiologists, if they reached out. Obviously, we couldn't force people to do anything with the information, but we can strongly encourage folks to share the information that's available in this program, share the legislation, and then hopefully think about the future of the program and future collaboration with deaf folks to improve the services that they're able to access. Something else to be aware of, public health it's like the daughter of the medical system. The medical system has a very clinical medical view of deafness. And everything comes from that because working in public health, they're usually former clinicians or doctors or individuals who have experience working with patients but are now more interested in working at the systemic level or the systems level. And so they often have a clinical view and they're clinically trained. So they're very stuck in their ways, I would say. And I think there needs to be some improvements. I think there are some considerations for SES, socioeconomic status, in communities that are served. They are now beginning to recognize people's languages, immigration status, and the public health system is better at recognizing these things than they have been. It's been a slow process, but Obviously, it takes time to make changes. There's been a lot of documents like the NOFO that have been developed by the government and distributed, like FAQs. But the language that's used in these FAQ documents is very clinical, and the folks who have worked on this program for about 20 years. There was one woman who worked on this who was a nurse. And so a lot of the documents that were disseminated were very clinical, talking about deaf kids as kids with hearing loss. And that's not a term that I like. And so I did see opportunity there to change the language so it became more neutral or more positive in ways that we talk about our deaf children. So there is clinical status with deafness. People who are deaf or hard of hearing have hearing loss. That's something that we recognize, and that's a medical term. But for community and public health services, we can use more balanced language instead of relying on the clinical vocabulary. More look at the whole person. So it's more of a social view of deafness. The medical view believes that the disability should be fixed, and deaf people believe that it's a very oddest attitude to try to fix people. And I do think that it's really important to recognize where those attitudes and views come from. This still exists now. So the definition of autism was created in 1977, so this is not a new topic, but people still don't know about it, specifically hearing people. They've never heard the term autism, and so I think it's our role to educate folks and work with members, stakeholder groups, to spread the word that this is challenging. Yeah, this is interesting. One of the consequences of this is that a lot of infants are not exposed to any language at birth. So this is just some examples of language that could be used in place of some of the clinical language. This is not an official change, but it's a suggestion of some better terminology to use. This is nice to be used in documents that is disseminated by CDC or NIH. I feel lucky to be able to have the opportunity to have influenced some of these agencies in their language changes. And it's a very simple change, but I feel very grateful that I was able to advocate for the deaf community while I was there. So this is a nice touchy-feely slide for you, just so you know that there's something in you that the world needs. So the point is that I brought in some deaf-related research to show my team, just to show that there is research that deaf people have done for deaf children on language development and cognitive development. These are a lot of outcomes showing the benefit of deaf children learning sign language. So even using sign language, having a cochlear implant benefits deaf children. So there is a lot more research that's going on right now that shows the benefits of learning sign language. So this is where I am now. I'm working with Dr. Wyatt Hall at the University of Rochester in his lab. He studies with the Visual Language Access and Acquisition Lab. So we've gone through California's EHDI system to figure out what information is received, the view on sign language, exposure to language, decisions that are made. So this is a really exciting project for us. So, I don't know if you are aware of this, but it exists. So, this is the deaf scientist pipeline that exists here. We did receive notification from NIH that most of this program has been canceled. So, I currently receive support for my training, tuition support, and a stipend through this program here. If not for this funding, I would not have been able to work with Wyatt and do my research that I've wanted to do. I have had to work for hearing researchers to do hearing-related work, and that's not something I've ever wanted to do. So this grant has helped me directly by allowing me to research deaf children and help me to research ways that I can change the system. But by cutting this program, it's going to impact other programs and other universities. So it's also impacting students here. And it's devastating. And this is information that we just found out. So the money that was established to create this pipeline back in 2015, we started building this pipeline through grants, through various programs. Bridges was the first one in 2013, then the postdoc partnership, URISE. And we finally received funding to create this whole pipeline, and then it was cut. And we're still all shocked and trying to figure out a way to move forward from this. And just today, just this afternoon, I found out that the EHDI program at the CDC, or the CDC, was cut. That entire office is gone. It no longer exists. That's huge. So we are anxious. We are worried about the state of the HRSA grants, NIDCD grants, and agencies are at risk. So there's a lot of people that are concerned right now in the field.
But we still do the work because we have to. We may often feel like there's no other choice. We see the need for this in our communities. We see the need for the systems to recognize what is happening. We see the gaps. And there's a huge gap in deaf-centered research on deaf children, which is where I work. As the more I work, the more I find about language deprivation and other impacts on deaf children, but there is not enough. We need more research in that area. That's why I left my job at HRSA to come do this type of research, because we need more research done by deaf researchers to support deaf children and their future, our community's future. That's very important to me, and it's very important to many of us. So feel free to reach out if you have any questions. If you'd like to chat, you can find me on LinkedIn or you can send me an email.
Thank you all for coming. Thank you to our interpreters, and thank you, Michelle, so much for your presentation.